Congratulations on the 20th anniversary of the Myocarditis Foundation. I'm proud to have been part of this journey and privileged to contribute alongside such a dedicated team. I wish I could be in person, express my gratitude. Unfortunately, due to unavoidable circumstances, I'm unable to. Still, I'd like to share a message about myocarditis, especially some aspects that are still not widely known: its causes, symptoms, biomarkers, and treatments. Last June, we held a meeting for 2025 Congress of International Society of Cardiomyopathy, Myocarditis, and Heart Failure, ISCMF, in Kyoto, in memory of my mentor, Professor Chuichi Kawai. This event marked the 19th year since the society was founded, 1 year after the Myocarditis Foundation was established. Dr. Cooper delivered an excellent lecture on the management of myocarditis during this meeting. Professor Kawai was active in Scientific Council on Cardiomyopathy of the World Heart Federation, originally founded by Dr. Fufui in the UK. I had the honor of succeeding him as a member. I also established a global physicians network on myocarditis and helped identify hepatitis C virus as a contributor to cardiomyopathy. Scientific Council on Cardiomyopathies paved the way for the creation of the International Society of Cardiomyopathy in 2001, which later evolved into the International Society of Cardiomyopathy and Heart Failure, ISCHA. In 2016, the ISCHA Congress was successfully held in Kyoto. Dr. Cooper, Dr. McManus, Dr. Fairweather, and Dr. Bruno participated in this landmark event. When I was working as a resident at Kaibara Hospital, a high school student with syncope accompanied by ventricular tachycardia came to my outpatient clinic. Dr. Tomita, vice president of the hospital, a classmate of Professor Kawai, suggested to consult to a new professor of Kyoto University, Dr. Kawai. Professor Kawai's diagnosis was subclinical myocarditis, which I heard this term at the first time. This patient became my first case of myocarditis at a time when few cardiologists even recognize the disease. After that, I joined Professor Kawai's lab as a graduate student and began studying viral cardiomyopathy and genetic causes. I developed several animal models of myocarditis using Coxsackie viruses and other enteroviruses. Eventually, I created models of severe heart failure using encephalomyocarditis virus. These studies suggested viral infections may also be the cause of diseases such as arrhythmogenic right ventricular cardiomyopathy, restricted cardiomyopathy, and even hypertrophic cardiomyopathy. Enteroviruses like Coxsackie virus, echovirus, and poliovirus can directly damage myocardial cells. Some viruses infect immune cells, which in turn damage myocytes. Leukocytes such as monocytes and the macrophages may serve a target for HCV, contributing to multi-organ inflammation. HCV infection has been linked to abnormality in the heart, liver, and kidneys. Cardiac hypertrophy was frequently observed in HCV-infected patients. In COVID-19 patients, measurement of biomarkers shows that SARS-CoV-2 can affect the heart, liver, and the kidney, not just the lungs. Cardiac effects of HCV include myocarditis, dilated cardiomyopathy, and hypertrophic cardiomyopathy, and other heart conditions. Major histopathology complex, MHC, plays a role in viral clearance and linked to hypertrophic cardiomyopathy, suggesting that immune genetic factors are crucial HCV-related heart disease. Genetic background also plays a key role in autoimmune myocarditis. Dr. Nishimura developed different disease models using PD-1 knockout mice genetically engineered to lack the PD-1 gene, an important immune regulator. In one strain, BALBC mice, we discovered severe myocarditis and heart failure. Although myocarditis was anticipated as a side effect of immune checkpoint therapy, real-world cases of fulminant myocarditis were only reported 15 years later. The organ affected by PD-1 deficiency depends on the genetic strains of the mouse, emphasizing how important genetic background is. C57BL6 mice developed groups like arthritis and kidney disease. NOD mice developed type 1 diabetes. These differences may link to variations in major histopathology complex known as AT2E mice, which controls immune responses. In viral myocarditis caused by EMC virus, severe heart inflammation occurs more often in BALBC mice, DBA2 mice, and C3H mice, while AJ and C57BL6 mice showed less or no heart inflammation. This suggests that immunogenetic factors strongly influence how myocarditis develops. Interestingly, loss of PD-1 also affects gut bacteria, disturbing the immune system and increasing inflammation. This highlights the critical role of gut microbiome in regulating health. What most people don't know about myocarditis, but should. It can affect the atria. One lesser known manifestations of viral myocarditis is atrial fibrillation. In a mouse model, AF was associated with inflammation, cell death, and thrombus formation in both atrial. Recently, immunoglobulin-free light chain FLCs have been identified as inflammation biomarkers in AF. Viral infection can activate inflammasome and NF-kappa B, increasing FLC production and systemic inflammation. We propose FLC's biomarkers of NF-kappa B activation. We found that FLC are useful biomarkers in myocarditis. In myocarditis with heart failure, the FLC kappa lambda ratio was significantly reduced. This ratio is a strong prognostic marker in heart failure. Adding the kappa lambda ratio improves predictive models beyond conventional. We compared various clinical variables between COVID-19 survivors and non-survivors. Significant differences observed in CRP IL-6, troponin T, NT-proBNP, and FLC kappa levels. Notably, there were no deaths among patients with low IL-6 level, whereas all patients with high IL-6 levels died within the first 20 days of the acute phase. These findings suggest that IL-6 is the most critical predictor of mortality in the acute stage of COVID-19. Early diagnosis of myocarditis is critical due to its potential for rapid progression. Comprehensive detection should include viral nucleic acid antigens, inflammatory biomarkers, myocardial injury markers. The presence of viral antigen alone without accompanying inflammatory markers or evidence of myocardial injury does not confirm the diagnosis of myocarditis. This slide shows anti-inflammatory treatments that have proven effective in animal models of viral myocarditis. Though some are not yet used clinically, treatment should ideally combine antiviral agents and anti-inflammatory therapies, as I propose today. To raise awareness, we must highlight the often unrecognized causes, symptoms, biomarkers, and treatments of myocarditis. SARS-CoV-2 and HCV are important viral causes. Atrial fibrillation is a key symptom. FLCs are promising biomarkers, especially in chronic inflammation. NF-kappa B inhibitor, fingolimod, and antihistamines may be promising therapies. Understanding etiology is a key to personalized treatment. Early detection is important for the treatment. If patient comes in with flu-like symptoms, checking following biomarkers at the same time can help catch myocarditis early, especially if viral antigens or nucleic acids are positive. These markers are markers of inflammation, IL-6, CRP, and FLCs, markers of myocardial injury, cardiac troponin I or T, and markers of hemodynamic stress, BNP or NT-proBNP. The diagnosis should ideally be done using point-of-care testing for quick on-site results to guide immediate treatment. A global network is essential to raise awareness of myocarditis, and foster collaboration in its prevention and treatment. We propose establish US-Japan network on myocarditis in collaboration with the Myocarditis Foundation as a first step towards building a broader Asian Pacific network. I wish the Myocarditis Foundation continued success and growth in the years to come as it continues to lead effort to improve the lives of those affected by myocarditis. Thank you very much.